Hello everyone, welcome to Perfectly Healthy Series. We have exciting guests today, Dr. Patrick Sewell, and I actually met Dr. Sewell through one of my patients. And I thought, oh wow, I love meeting outside the box doctors, and Dr. Sewell is definitely outside the box, even though he has a conventional background very similar that I have. He's an interventional radiologist. I'm a conventional medical doctor from, residency training in conventional medicine. And so, but as we know, when we went to medical school a long time ago, things were very different than they are now. And I always tell people, we are practicing updated medicine. And new things are coming out all the time on PubMed. There's 1.2 million PubMed articles online. There's no doctor that can possibly keep up with all of the new inventions, the new procedures, the new, new studies, everything. So tonight you're going to hear the latest and greatest from Dr. Patrick Sewell. I want him to really go through his history of, become an interventional radiologist, and then how it transformed into what you're doing now.
Sure. Yeah, so I'll start off with like the Aaron said, medical school and in Louisiana and Mississippi, where I grew up. And after medical school, I went into internal medicine and then diagnostic radiology. And that was 6 years of residency. After that, I did 2 fellowships, interventional radiology and cross-sectional imaging. And then I stayed on at the university as a faculty, and I started a new field called interventional oncology, which is interventional radiology but dedicated to treatment of cancer. And I developed some new technology, cryoablation, radiofrequency ablation, microwave ablation, developed some new procedures, ablation of certain cancers. I had research projects that were incredibly interesting, new imaging technology, interventional MRI. I had a great project with NASA where I built this robot on the space station that you could operate on an astronaut from the ground. The doctor could. I had a software company that rewrote radiation software, radiation imaging. So now you get 10% of the dose of radiation that you used to get prior to my company's revolutionary software. And then I got into, because of cancer, I got into stem cells and gene therapy. And so now a large part of my practice is interventional oncology with a focus on anti-cancer gene therapy. And so all that's going to be included in the presentation today.
So everyone knows, or if you don't know, I'm an integrative functional medicine doctor, and I'm the medical director at Center for New Medicine and Cancer Center for Healing. And so we have an amazing staff that do everything from phlebotomy to scanning to bioenergetic testing to treatment. And so I'm very privileged to get to see all the incredible people I get to see every day.
Yeah, this is me. But basically this says what I've done, some of the highlights of my career. I was very fortunate to be in the right place at the right time. And I'm incredibly thankful for the journey. I didn't plan any of it, but it's been a wonderful experience and still is. So this is my company, Triple Helix, and I'm the chief scientist. I'll focus on developing new therapies and instituting them. And so I thought I would start, the initial part of the talk would be an example case, a typical case we get. The 62-year-old patient in London finds a breast mass on physical exam, and through the normal channels, they work it up, they biopsy it, and she's diagnosed with triple negative breast cancer. Sometime later, at the time, the cancer appeared to be localized by all the best technology, the best analysis. There was no evidence that it had spread anywhere. So the patient had the means to go seek out, the best care. They flew over to Dubai to see an expert there who gave them chemotherapy before the surgery, which we call neoadjuvant therapy, chemotherapy. Then they did a total mastectomy of the right breast and radiation therapy. And then she went home And months, 6 months, 8 months later, she found a lymph node in her axillary region, and which is worrisome, because that suggested that it might be a residual tumor recurrence. So we worked up the lymph node: physical exam, ultrasound, MRI, PET scan, liquid biopsy, and these are all the things that one should do when staging a cancer initially, and including the NGS testing and the genomic tumor analysis. And those last two are very, very important because they give us a foundational analysis of the tumor, what the DNA of the tumor, so to speak. And tumors differ in many ways, but fundamentally they differ at the genetic level, and that dictates often aggressiveness or non-aggressiveness. It also dictates how tumors, what they'll be receptive to, what chemotherapy, what therapeutic agents they'll respond to. So if we do, these days, you do a biopsy and you should do a genetic analysis of the tumor because it gives you personalized information about that patient's tumor. This would be breast cancer, and you could have another person with the same type breast cancer, but they could have totally different DNA tumor and therefore respond totally different against the same chemotherapy agent, or have different tumor suppressors turned on or off in their tissue. So this NGS, which is next generation sequencing, it's a DNA sequence. It tells us the exact makeup of your tumor and what we need to do about your tumor, and in the same area of breast cancer. So it's dramatically personalized. We're to the point now where we shouldn't treat cancer anymore as a class, like all colon cancers get this and all breast cancers get that. It should be based on that person's genomic sequence of their tumor. And so that's literally what we do for the last few years. The testing in this patient did reveal recurrence of the breast cancer, which brings me to a point: how could she possibly have breast cancer if we took all the cancer out and all the studies showed that there was no cancer, and what was there we took out? Because there are limitations to the staging, to the analysis. There's not a scan in the world, not a PET scan or an MRI scan or CT or ultrasound or lab test that can find a single solitary tumor cell in your body. And one tumor cell is all it takes, potentially, to multiply into more and become a recurrence. So at the time, to the best of technology and everybody's methods, she appeared to not have any other cancer anywhere, but obviously something was elsewhere because it eventually showed up as a mass months later. Now, what do we do with that? We do a genomic analysis of we biopsy the lymph node and document that it's malignant or cancer, and then that particular tumor, even though it's still breast cancer, it can be genomically different. So we have to do a genomic analysis on that tumor because it will have mutated compared to the prior breast cancer, and thus the mutation will confer resistance to certain drugs that may have worked previously, or open up drugs that will work on this mutation but wouldn't work on the first one. So it's the same cancer but a cousin of the first cancer. So new assessment, new problem, new plan. Recurrent triple negative breast cancer in this patient. This means this patient has and also the genomic analysis. It doesn't do just the tumor, but it does a genomic analysis of other cells in your body. And so with this patient, I found out she was also 15 more times likely to get Alzheimer's disease compared to a normal patient. And I got that information for free through the genomic analysis. It turned out both her parents had Alzheimer's disease. So now if I'm doing a gene therapy, it raises the possibility of treating both diseases with the gene therapy. Well, we're going to handle the breast cancer for this talk. So this patient underwent cryoablation, intratumoral immunotherapy, and anti-tumor gene therapy.
So you might want to talk about
Yeah, I was going to start off talk about each of these. So cryoablation is a technology I invented literally in 1998. At the time, I did the world's first renal cell carcinoma cryoablation, percutaneous. and went on to treat hundreds of patients. And now it's a routine procedure that there are many people trained and specialized in it. It freezes the tumor, not just kidney tumor, but many tumors. It freezes the tumor and kills it, just like when you freeze a wart. There's some caveats to it, depending on what organ you're in, if it's lung or liver or kidney. But the mechanism by cell death is if you freeze a cancer cell or a non-cancer cell, the water expands and ruptures the cell membrane, and some other things happen too. But it's a mechanical destruction through the freezing. So we use it as one of the tools. And with cancer, we use all our tools possible, and not sequential, but all at the same time. Because as I mentioned earlier, this tumor had mutated. Tumors mutate with time, and this tumor mutated and was not receptive to prior chemotherapy agents, and was receptive to agents that the other one wasn't. So if you delay your treatment and you slow play your treatment, you set yourself up you allow your tumor to potentially, and very often does, mutate and change how it's going to behave, what it will respond to. And then you have to come up with a whole new game plan. So it's best to hit it hard and fast. The other treatment this patient got was intratumoral immunotherapy. And a lot of you probably know about immunotherapy. It was a game changer in 2015 when it came on board. And there were initially one immunotherapy, then there were two, now there's 7 approved in the United States. And outside the United States, there's 29 that I can use. Some are research. But basically, immunotherapy uncamouflages a cancer. Cancers are very sneaky, and they hide from the immune system. Normally, as you go through life, before you get a cancer, before you get a diagnosis of cancer, you have cells that mutate and turn into cancer in your body. When a fetus in utero gets a cancer, a cell can become cancerous. But the immune system sniffs it out and kills it, and so it never grows into a mass. Later on in life, when your immune system begins to fail, it's aged and it's not as skillful, it starts making mistakes and it misses cancers. And those grow into what we call a cancer because it's a visible mass or it's causing problems or symptoms. So immunotherapy helps the immune system recognize what it couldn't recognize without the immunotherapy. So that was a big boost. So that's a huge tool too. And you can get it intravenously or get it intratumorally. You can't get it intratumorally in the United States right now because of research, but soon you'll be able to, maybe in a couple of years. But we use it all the time outside the United States.
So give them some examples of the immunotherapy. Keytruda,
Opdivo, Yervoy. They all have really weird names that you can't pronounce too, but those are the trade names.
Yeah.
And those are 3 of the biggies.
In the United States. Yeah.
Yeah, in the United States. Yeah. They all usually end in MAB, something MAB, blah blah MAB, blah 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 MAB. So MAB means monoclonal antibody, which is what they technically are. So the cryo, the ablation, the intravenous or the intratumoral immunotherapy, the chemotherapy, low dose, high dose, multiple combination chemotherapy, these are all tools in the bag. Now, we have a new tool in my company called anti-tumor gene therapy. And like I said, this is because it can exist only because we can now genomically declassify the tumor or evaluate it. And so when I get a genomic analysis on the tumor, and I mentioned the tumor is very sneaky. So in a normal cell, there are what's called tumor suppressors. One of them is P53 or TP53. Another one is P10, capital P, capital T, capital E, capital N. There's one called RB1. They have weird names, but they exist normally in cells and they suppress tumor growth. Well, tumors turn off these tumor suppressors because they want to proliferate, and they're very sneaky in that way. But with gene therapy, I can reinstall these tumor suppressors back into the tumor, and by doing that, the immune system has a better chance of fighting the tumor. The immunotherapy has a better chance of working. All works in concert. So the anti-tumor gene therapy is another huge boost, as big as immunotherapy. It's going to be as big as immunotherapy. It's really big in my practice, and it makes a huge difference. So, if I had to give numbers to it, if you had a tumor that responded to chemotherapy 15% of the time, if you add immunotherapy, you're going to be above 50%. If you add anti-tumor gene therapy, you're going to be in the 80%. All three of those. The more tools, the better response. There's a caveat to that. The more tools also means more chance of allergic reaction or adverse reaction. So it's a difficult and a delicate dance. So it has to be done correctly. So it's important to follow all the dot your I's and cross your T's and do things correctly. It's not magic and it's not a panacea for all tumors, but it's a huge leap in what we have been able to do previously. A little bit about more about the cryo. I said it kills the tumor by freezing it. But what it also does is it sparks the immune system to make anti-cancer antibodies, like the immunotherapy does, like the gene therapy does. We've known this for 25 years. The problem is it's only 3% of the time does it spark the immune system to make anti-cancer antibodies, and I don't know who it's going to happen in. So 3% of the people get this benefit, and for 20 years we've been trying to cause this to happen on purpose, cause the immune system to make antibodies, and now immunotherapy was the key to that. The antibodies go all over at the cellular level and fight cancer. The antibodies that your immune system makes normally on the mutated cell before you have the diagnosis of cancer that eradicates that cell and thus you never get cancer, the same type of antibodies are produced by your immune system to fight your existing cancer now that escaped the immune system. The cryo and the immunotherapy allow the immune system to take on that capability again. It allows it to recognize the cancer for the first time and then make antibodies against it. If it can recognize it, it can classify it and build a therapy for it, which is an antibody. Now, mechanically, cryo is very simple. It looks like a biopsy needle. It's a little ice pick, and you stick it in the tumor, and you turn the machine on. It's a sophisticated argon and helium gas under pressure, and it freezes things and heats them up. Anyway, and you pull it out and you put a little Band-Aid on it. So it's a pretty cool. It's not open surgery, and recovery is pretty easy. Now, immunotherapy. Like I said, it boosts the immune system, which occurs from cryo. The intratumoral immunotherapy, I inject directly into the tumor, cryoablated tumor, because I do the cryoablation and mix the immunotherapy in immediately, because there's injured tumor cells and dead tumor cells that are busted open. So all the details of the tumor cell are visible for the immune system to swoop in and look at. And while they're laid out in the open, the immunotherapy primes the system to come in, these T helper cells, and the T helper cells come in and look at everything, and they say, that definitely doesn't belong here. And it instructs the T cells to make antibodies against it. And that results in like a 10x increased tumor response, the immunotherapy, as opposed to just the cryo. Now, the anti-tumor gene therapy, I alluded to a little bit. We reinstall tumor suppressor cells into existing live cancer cells that haven't responded to the other methods. So it's an additional therapy. These tumor suppressors shut down the tumor metabolically and handicap it. It's not nearly as strong. It doesn't grow nearly as fast. It may not even grow anymore. It might just exist, but you now have a chance for the antibodies to get a hold of it when it was really growing out of control, despite your efforts. Now the immunotherapy, the immune system can attack the tumor. Once it recognizes it, it will go everywhere in the body and attack any identical tumor. If your tumor elsewhere mutates and is different enough, that explains why immunotherapy fails. But if you go fast enough and don't allow it to mutate, you increase your chances of getting all the tumor that matches all the tumor in your body, because it might be identical. All right, now, briefly, since I have to talk about this since I mentioned it in this patient's history. The genomic analysis uncovered Alzheimer's disease risk, so I was able to correct this patient's risk of Alzheimer's disease by doing anti-Alzheimer's gene therapy, installing genes that the patient had mutated that were going to set up to cause Alzheimer's. So it's just like we do with the anti-cancer gene therapy, but it installs it into normal cells for a different reason. All right, so what does this lead us to? Well, we call it personalized medicine. It's here now. It can address cancer, most diseases, inherited and acquired, and this is the focus of my company, Triple Helix. Generally, a few more slides to talk about the approach. The ablation and the immunotherapy debulks the tumor, and I want to emphasize it turns it into an antibody generator. The goal is not to destroy all the tumor with the ablation, is to just kill a little bit so it's exposed to the immune system. If you kill too much tumor with the ablation, you can shut down the immune response. So it's a delicate balance. And then the anti-cancer therapy reinstalls tumor suppressors. Interestingly, the anti-cancer therapy has very few side effects, if any. Typically, we do this by, the ablation and immunotherapy as an outpatient procedure, and we don't do it in the United States because it's not allowed yet. We do it in other countries all over the world. And that's considered phase 1. And then phase 2, a few months later, we've built the gene therapy in the lab, and we come back and administer the gene therapy. We're on the verge of having off-the-shelf anti-tumor gene therapies that'll cover 80% of most people's, but there's always going to be a personalized component because everybody's cancer is a little bit different. So in short, a little bit of my work, I treat 17, 18 different kinds of cancers, even subsets. A lot of patients over the last 8 years, many thousands over the last 22, 25 years. Most of my patients, almost all, come from oncologists or other patients, and many are at their last stage or are considered incurable. Despite that, we have a really good track record. We can't cure everybody, but way more with these methods than if we didn't have these methods. So a lot of my patients are limited by what they can get. So they in the United States, so they come outside of the country. But some of this is available inside the United States as well, which is good news. And it's going to be more and more. All right. Anything else? I know that was fast.
Yeah. Well, and one thing that we do here, and Dr. Sewell knows that, is about treating the terrain.
Yeah.
You know, the garden that the cancer came into.
That's all about the immune system. It's
right.
the same, the immune system, if you can fix the immune system or boost it, that's your best bet against cancer, period. And that's what the center here does, and that's what I do. We use different methods. Mine's more focused on the immune system pertinent to just that tumor, but the general immune boost and specific is very important. It's the key, basically.
Right, so these are, cancer is evolving. The conventional treatment of cancer, doing surgery, chemo, and radiation, that's been around for about 60, 70 years, we know it has a very, very low efficacy rate.
Yeah.
You cannot just do that.
No. That alone is malpractice.
Yeah, exactly.
A good treatment plan is everything that possibly might affect the tumor that the patient can tolerate. And as rapid a time as possible. You got to hit it when it's down. Waiting around or doing it back to back, do surgery, then chemo, then radiation, then blah, is the wrong approach. And it's going to take a while to reprogram the system to do that, because unfortunately it still does that, unless you find somebody like us who are out on the forefront. But I'll tell you this about the immune system. The ultimate cure of cancer is going to be based on the immune system. 95% of cancers will be cured if you can correct the immune system's error in addressing a cancer. If the immune system didn't degrade and didn't develop faults, 95% of cancers probably wouldn't occur, and this wouldn't be the problem it is. So that's the ultimate target, and that's what cancer research is working on, and that's what Aaron's work here is about. We just have to get better at it and more specific and be able to manipulate it better. The immune system is incredibly complicated, super complicated. Most people, hardly anybody, well, I don't know if anybody fully understands it. I certainly don't. But with time, we get more knowledge about that.
Right, it is for every disease. It's not just for cancer.
Yeah,
the
exactly.
immune system is
all the autoimmune diseases.
Yes, it's heart disease.
Yeah.
Every disease is related to the immune system. So if you can optimize your immune system, that's where you're going to have the most winning victories, is with that. So okay, so how do we put on for questions?
There's a couple pre ones that we received if you toggle down.
Oh,
and
yeah,
then
yeah.
Okay.
In the chat section, people are asking live questions.
Okay.
Let's see, how do we get to the chat section?
Oh, right there's the first question. Right
Can immunotherapy or gene therapy be applied specifically to Crohn's disease? Yeah, so Crohn's disease is a multi-genomic problem. There are some gene therapies that can help Crohn's, but not cure it. Down the road, mastering the immune system will be the cure for Crohn's. But right now, unfortunately, I have Crohn's myself. If I could develop a gene therapy for it, I would have done it by now. And unfortunately not. But possibly in the future. But certainly we have some gene therapies now that can reduce the severity of Crohn's and reduce the flares and reduce the chance of having to have your colon, parts of your bowel resected, etc. Staying out of the hospital, definitely.
And with any disease, you've got to get rid of all the thorns, the things that are contributing, whether it's stress, whether it's nutrient deficiency, whether it's microorganisms, viruses, bacteria, fungi, parasites, mold and Lyme, etc. You have to also optimize the hormone system. You've got to optimize the immune system. You've got to optimize absorption because Crohn's, the gut is not working, so you've got to optimize absorption. You've got to get rid of toxicity. You've got to address heavy metals. And we're all living in the great poisoning with the world today. So it's very, very functional. Very multifaceted with, any disease process. So this person, they typically give the patient immunotherapy drugs, which there's a price to pay for those drugs.
Yeah. Okay,
they cause cancer. And so, you've got to rebuild from the ground up, period. With Crohn's disease. I know I've successfully treated Crohn's disease, but it takes time, and the patient has to be a very avid partner in going through all the steps and keeping your gut healthy.
The issue with Crohn's is, and the immune system is, it's not a faulty immune system, it's a mistargeted immune system. And so, everybody's with Crohn's, their immune system is unique to them, and how it's mistargeted is usually unique to them. And so that's why it takes time to get the immune system maximized in a certain individual, because you can't just test and know what's wrong. You have to, by trial and error, get it better, and that means time. But the immunotherapies, the drugs that you get for Crohn's disease now, the biologics, those are technically immunotherapy drugs. And you probably know them, whoever asked this question, Remicade, etc. They do have side effects. They have benefits and side effects like every medication.
That's right.
Oh, Keytruda for 2 years with some shrinkage of all nodules. What is next? All right, so here, can you stay on Keytruda until nodules are gone? I don't have genetic testing. No, what do you recommend? Yes, I recommend you get a genetic testing because the genetic testing of your lung nodule, any one of them, will tell us what mutations have occurred in your tumor, and they're going to be different than they were 2 years ago when you started this. Number one, so if you had a genomic analysis 2 years ago, it wouldn't be unusual for you to quit responding to Keytruda because some of the nodules mutate, some of the cells mutate. So yeah, you have to assess every now and then. You can stay on Keytruda forever, but you don't want to. Roughly 50% of the people who start an immunotherapy intravenously have to stop taking it at 6 months because of prohibitive side effects. They can have horrible side effects. I've known people that have stayed on for years, and some of them do fine, but a lot of them, half of them, can't take it. Right. And if you add 2 together, then that percentage goes even higher, and 3 together even higher. Your complication rate, side effect rate skyrockets with multiple drugs, multiple immunotherapies, but multiple immunotherapies are more effective than a single one too. So for you, I'd suggest a biopsy and an NGS, next generation sequencing is the term. It describes the tests, the group of tests. There's a bunch of companies that offer them, but NGS analysis is what you want of your lung nodule. And from that, it'll open up, it'll reveal what therapies, other therapies will work on your tumor. Okay. How long should a person be on immunotherapy? I kind of answered that obliquely. It depends on if they want to be, and if they still have cancer and they can tolerate the side effects, and if there's no other alternatives. But to answer it better, you need every therapy possible that you can tolerate, that'll have an effect, and all combined together possibly. That might be more than one immunotherapy, or it might be immunotherapy plus another biologic, etc. Does it have diminishing effects over time? No. It can diminish. It can appear to have a diminished effect because the tumor mutates, and that new tumor doesn't respond to that immunotherapy. It never would. It never did. Also, the tumors that do respond to immunotherapy can be mixed in with tumors who don't, and so all the ones that do respond die off, and all of a sudden your tumors appear to be not responding. Well, those are the ones that never responded but are now growing and replace the ones that did respond. Can a person be put on it again after cancer back? Yes, it'd be pertinent if their cancer still is susceptible to immunotherapy based on the genomic testing. Would immunotherapy, gene therapy be helpful in treating retroviruses like HTLV1, and would it lower the viral load? Yes. Additionally, are either of these treatments helpful for viruses like Epstein-Barr, cytomegalovirus, and herpes? So we're working on. I have a HSV herpes gene therapy in development right now, and if it works like I should, it will cure people of herpes type 1 and 2. Cytomegalovirus, similarly, Epstein-Barr possibly too. Those would be different gene therapies. It's a complicated answer, but the short answer is yes, depending on some other factors.
Right, and there are some treatments for viruses already, natural treatments, different things, propolis. There's immune activation for your immune system. You have SOT. SOT is supportive oligonucleotide technique, which is kind of similar to some of the things Dr. Sewell is doing. It works great for herpes. Haven't found it to be beneficial for Epstein-Barr, but it does work for herpes and Lyme. So basically, they reverse engineer a new messenger RNA to disrupt the DNA of the virus. So there are things, the regular things out there don't work. There really isn't any medicine. There's Zovirax and Famvir. There's antiviral medicines that are worth a try, but for long-term management, you're going to have to do things that try not to hurt you.
It's about the immune system again, too. The reason your cytomegalovirus or your Epstein-Barr virus or your herpes or your varicella zoster, shingles, the reason they manifest clinically is because your immune system is weakened against them. And so one method is attack the virus along with the weakened immune system, and one method is strengthen the immune system. And Leanne just talked about ways to strengthen the immune system. Another thing I'm working on is a gene therapy to rejuvenate the thymus gland. And the thymus gland involutes at age 40, and you lose a huge component of your anti-infectious part of your immune system, your one of your T cells. Yeah. And so by rejuvenating the thymus gland, bringing it back online, that component is back again, and it then will likely have, in many cases, will have the ability to fight the virus better. So it goes back dormant, clinically dormant. It may even be able to eradicate it from the neurons where it's hiding, or the cells it's hiding in. So that's coming soon, this decade for sure. All these treatments are about tumors with immunotherapy for different kinds of blood cancer. Yeah. So yes, gene therapy and immunotherapy will. In fact, immunotherapy came about. Its foundation was in blood cancers, leukemia, lymphoma, etc. That's where it made its big impact. But there's CLL, there's ALL, there's CML, the various leukemias. There's other lymphomas, many types of lymphomas. So yes, the more immunotherapies are coming out, and gene therapies will definitely play a role. Right now, I've been focusing on solid tumors for gene therapy, but that is an area of interest, and an area of research is the blood, what we call blood tumors, or non-solid tumors. All right, okay. Here's a patient, non-small cell lung cancer, 2023. blah, blah, blah. 2 centimeter tumor removed with a wedge, clear margins, positive 7 months post-surgery. Okay.
Positive circulating tumor till 7 months post-surgery.
Oh, okay. Yeah, so at 7 months it came back? I mean, it was detected again?
I
What?
think they checked, they had clear scans, which is great,
Okay.
but she had a circulating tumor
Oh,
cell
I see,
test,
positive CTC
which
test.
is, so hopefully you're addressing the circulating tumor cell test.
Yeah,
And she wants to prevent, obviously, a reoccurrence, that's right. So, and she's hopefully gonna come here, that's good, that would be a good idea, then we can take the deep dive and figure out everything that we have to do to optimize the immune system, all the things you're talking about.
Yeah.
So,
so your case, there's no short answer. We need a whole lot more information. And yes,
And a
dendritic
good
cell
one.
therapy,
Yeah.
all the things you're mentioning, all the things we mentioned, plus dendritic cell therapy, plus others may play a role. But that's good news. There's
Right.
a lot of potential treatment options.
Yeah.
Other than what you've basically had was the basics. What we consider the basics now.
Right.
Yeah.
And the good news is if your scans are cleared, that's like the best case scenario.
Yes.
So this is when the work needs to be done right away.
Exactly.
So to prevent a reoccurrence.
Treat you now while you're healthiest
Right.
and your tumor burden is smallest.
Right. Exactly.
All right.
Can you access the chat? We have a lot of questions.
Okay, how do we do that? Chat.
Good question.
Let's
Do you
see.
know?
Yeah, so I saw somebody look for NGS. It's very confusing. It is very confusing. Try next generation sequencing, or as a search term, or try a tumor DNA analysis or tumor genomic analysis. Those are other search terms. And can I explain a little? Oh, can any of your tools get rid of 30 plus years of Epstein-Barr causing chronic, blah, 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 blah. Yeah, chronic fatigue syndrome. Possibly, yes. We need to evaluate you, but yeah, we can often do help chronic fatigue syndrome, depending on the etiology. It might be Epstein-Barr is going to contribute, but it could be other things. But we need to evaluate you and see. It's often multifactorial.
Right.
Can you explain more about NGS? You biopsy the tumor, you get a piece of tissue, it's sent off to a lab, they examine it in the lab and break down the components to see literally what genes are in the tumor and which ones have been turned off and turned on. And then they make a report and they send it back, and that gives us the information. So it's basically a biopsy sent to a special lab, a company, and there's a bunch of companies out there to do that. True Diagnostic, no, not True Diagnostic. You remember any off the top of your head?
Fulgent.
Fulgent,
Which is what I use a lot here.
Yeah, Fulgent, Foundation One,
Tempus.
Tempus, TMPUS. These are all names of NGS, NGS testing from different.
Yeah, those are True North. Not True North, but something North. I
Yeah.
forget. I don't use it, but I use Fulgent primarily at the clinic, and that looks like the P53 and all the other.
Yeah.
You saw you mentioned
TP53 and P10,
and all
etc.
that.
Those are,
So-
I'm pulling up a list real quick, if my computer will work quick enough, of NGS. But while I'm doing that, I heard that immunotherapy by mouth over a period of time can help with Lyme disease. Is this true? I don't know anything about that.
What was that?
Does oral immunotherapy help with Lyme disease? That's his question.
Well, Lyme disease, again, like we've mentioned before, for any disease, everything is multifactorial, okay? You've got, any doctor's got to go down the rabbit hole to all the different facets of what's going on and really do it. Very good blood testing, bioenergetic testing, everything. And Lyme disease is one of the, complicated, illness. And yes, everything is about the immune system. So we always order an immune system panel on our patients, looking at B cells, T cells, natural killer cells. And then we build a protocol specifically for Lyme. And we also use the Lyme SOT, the SOT, but it's also getting rid of all the low-hanging fruit problems, whether you have a high inflammation level, high blood sugar, all kinds of different things. Ozone is very good especially good for Lyme. And so I would recommend that you do that. There also is a frequency, if you look up the Nikki frequency device, and that's a device because the founder of the company, his whole family had Lyme, and then they figured out what frequencies, and you wear it, wear the frequencies to destroy the Lyme. So Lyme is one of those really tricky organisms, but it can be managed and it can be treated. So always looking for a shotgun approach for medicine is never a good idea because it's always layers of healing that have to take place.
Yeah.
So,
all right, so next question. I had Keytruda treatments while going through chemotherapy, but treatment for triple negative breast cancer. Received PCR at the time, double mastectomy, remission for 2 years, have the BRCA1 gene mutation, wondering what could be done in the future. So triple negative breast cancer is notoriously difficult, but not so much anymore. Gene therapy definitely can play a role, and I'd be happy to talk to you about that at length. It's a discussion more than a simple answer. All right. Would this therapy be effective for treatment of MBC?
metastatic breast cancer.
Yes, gene therapy can.
For Tabra, yeah.
Yes.
We'd need to know more pathology and obviously more markers and all that.
And the genomic analysis. Any tumor, to treat any tumor with gene therapy or with the proper immunotherapy or even chemotherapy, an NGS is going to be key. How does one go about getting NGS? Oh yeah, I'm going to get to that. Your opinion on incorporating fenbendazole, mebendazole, and ivermectin.
So we do that regularly on a lot of the patients. So the doctors here will prescribe that. And is our GCC helpful? Yes, we do that on most of the patients. It's not for brain tumors, but it's helpful for blood cancers and or tumors. And it gives you sensitivity testing to what is the best chemo, what are the best natural things. It also will identify growth factors. RGCC also has treatment for, like I mentioned earlier, Lyme and some of the viral therapies, so with SOT, so yes.
I don't have good internet, so over here for some reason. Okay, let's see.
I answered that one.
Okay.
Yeah, the Nikki device, yes, right.
I just gave it.
Oh, okay, perfect.
What if the immunotherapy raised your inflammation and now your immune system is attacking? So that's what we call graft versus host disease, or autoimmune disease, basically. Yeah, when your immune system can attack your body, that's a mistargeting thing, and generally we call that autoimmune disease. But if immunotherapy treatment is the cause, then we kind of call it graft versus host disease, although it's not entirely accurate. But basically, it's the same thing. Yes, you can stimulate your immune system accidentally incorrectly, and it can attack your own cells. Now, what do you do for that? You have to inactivate the immunotherapy, and that's done with steroids or other biologics and immune modifiers. And the devil's in the details. It's definitely doable. Be happy to give you my opinion anytime with specifics. Do you treat people with ALK cancer? ALK. I'm not sure. I don't know what ALK is. ALK. If Jamie can tell me what she means by ALK. ALK mutation. I don't know which cancer that is. I tell you what, email me and ask me. When I can't look it up right now because I don't have internet.
Oh, the mutation, yes. That makes sense, yes. Yeah, it's not a cancer, it's a mutation in the lung cancer. That's what it is. Right.
Oh, okay. I haven't treated ALK mutation itself, but that doesn't mean it can't be done. I'll look into it. My email should be in the chat or posted. You feel free to reach out to me, anybody, for questions that I haven't answered today. The ALK is a long answer, so I can't do it here, but let me find that NGS.
Have you ever heard or treated
HLRCC.
C or pH division RC. Also, what is the protocol for people that have the majority of their masses in the lymphatics?
Are you talking about renal cell carcinoma?
Yeah.
Oh, yeah. Well, have you ever heard of treated HLRCC? You mean have I ever treated HLRCC? I've treated just about every kind of renal cell carcinoma on the planet. So, I mean, it's actually one of my specialties. That's one of the first things I did was invent a treatment for renal cell 25 years ago. So, yeah, feel free to give me specifics by email.
Mm-hmm. On appendicitis.
Yeah, appendiceal cancer. I've treated some appendiceal cancers. Yes, it's doable. Again, the details, feel free to email me. It's all about the details.
Yeah, it's all about these very individualized, personalized treatment.
Okay, let's see.
Did you already say which other countries?
Which other countries for what?
I'm not sure.
Maybe we're I don't know. Mainly, I do some in Asia, some in Europe, but mostly in Mexico because it's near where I live. And but yeah, if you want consideration or have a question, just feel free to email me. I have a 2-centimeter mass near the kidney, all showing up since October. Well, if it's near the kidney, it's not a renal cell. If it's near the kidney, it could be a lymph node or it could be a adrenal tumor, depending on its location. I need to see the scans and what other records you have to know. But that's usually, this is a common presentation. A mass shows up, what is it?
Mm-hmm. Right.
All right.
So you never know what the mass is
Yeah.
until you
got to biopsy
it, unfortunately. So.
Yeah. All right, let's see, come to the top. What's the protocol if masses are all over the body, the lymph system, and the organs? Well, the protocol is it's to either have primary or metastatic cancer, and so that's one division, and then the other division is what organs are involved and what's the tumor burden and what's the critical organ, is how you go about it. And then the exact mechanism of treatment depends on the cell type of the cancer and the NGS, etc. So I can't answer that directly, but I can give an answer with more information. Will this work for brain cancer? Yes. There are I have some gene therapies for brain cancer. There's some new stuff with brain cancer. Dendritic cell therapy shows great promise. Glioblastoma, this is astrocytoma. Oh, grade 2 astrocytoma. Surgical remove, remainder is not operable. Well, that astrocytoma grade 2 with residual tumor is a prime candidate for this type of therapy, as there's no other therapy that was going to work other than these new therapies. Can you do cryo on a 5-centimeter thyroid tumor invading the esophagus? Not invading the esophagus. Well, yes, you can, but the esophagus will be damaged, so it would take you'd have to have a cardiothoracic surgeon that could repair the esophagus as well. So that would be a combo approach that I've done many times. Freeze the tumor, knowing you're going to damage the esophagus, surgically repair the esophagus. Right. Separately, cryo it alone is not adequate. Surgery is not adequate. They both carry negatives. When you combine the two, there is opportunity to deal with the negatives of one through the other techniques. Where is my office outside the United States? Several offices. If you just go to my website, you can ask all these questions, triplehelix.com. It's in my email. My email is patrick.sewell@triplehelix.com, but Triple Helix is spelled a little uniquely, so you need to pay attention to the spelling. Let's see. Do I treat seizures? Yes, I do treat seizures. A lot of my work is with stem cells and regenerative medicine, and even some gene therapies are pertinent to seizures too. Seizures unresponsive to other therapies or breakthrough seizures particularly. How effective is this for treatment of prostate cancer? So there's some new immunotherapy stuff out there, protocol for prostate cancer, even widely metastatic prostate cancer with bone therapies that shows the best promise of anything in a long time. I'm also working on some gene therapy for that, but there's some options for prostate cancer, yes. Better than what existed before immunotherapy and gene therapy. Is it safe? Cryoablation of pheochromocytoma. I've treated adrenal cortical. I've treated a pheochromocytoma twice with cryo. It can be delicately done. There's a huge risk of hypertensive crisis and stroke, so I have to do medical management and get their with IV medicines to keep their blood pressure low. But yes, it's possible. It's not. It's risky, but possible. Of course, there's no good therapies that aren't risky, actually. How effective would this be for kidney metastasis to the lung? There's some very good therapies. Some I've talked about for metastatic renal carcinoma to the lungs. Do you treat IPT? Is that idiopathic? No, I was thinking idiopathic pulmonary thrombosis. ITP.
Yeah.
Yeah. So we have some options for ITP. Yes, some gene therapy options. Yes. How effective is the treatment for thyroid cancer tumor that has spread to the trachea and vocal cords? Yeah. So the problem with tumors that's invaded a structure that you don't want to, that causes problems is the treatment. A mechanical treatment is often problematic, but it's possible to do gene therapy or immunotherapy on such a cancer and only affect the cancer cells in the vocal cord or the trachea, and also do some regenerative medicine and allow healing of those tissues. It's a tightrope, but it can be done. It's possible. Can any of your tools get rid of? We had answered that one already. Okay. GI problem, have the same problem. GI, I have the same problem. I'm not sure if that means ITP or some other. Okay. So whoever, P. Brown, if you want to give me some more details about GI, I have the same problem. I could answer.
Can't see that.
What else? Let's see.
Well, that's a good question.
Yeah. Okay. Anybody else? Let me see. If I missed a question, I guess repost it. It'll show up at the bottom maybe. Let's see.
Repost it.
Yeah,
or email.
Or email, yeah. Would you, here we go. Do you treat grade 4 glioblastoma multiforme? Yes, I do. What's the recommendation of the cancer has decreased in the breast but gotten larger in mostly one lymph node? Hormone sensitive. It's going to be the same genetic analysis and sensitivity testing to see what the tumor responds to. This is a typical scenario of a mutated tumor where the primary behave one way and the secondary the metastasis is behaving differently. That indicates it's mutated and you're dealing with a different breast cancer in essence. Have you had any success using immunotherapy for someone with less than 1% PD-L1? It's very difficult the problem with the less than 1%, if you don't have a high tumor mutational burden, TMB, or a mismatched repair, MMS, if you have a stable, then the immunotherapies don't have much to contribute. They still contribute, but it's a tiny amount. So I still use them, but you have to give additional therapies as well. Often immunotherapies can do a good job with cancer in general, but if your PD-L1 receptor is very low, your mismatched, your MMS or your tumor mutational burden is normal or low, then no immunotherapy is going to work.
Right.
So there's nothing for it to work on. How is the genetic test different from the foundation? The foundation one is a genomic test. It's important. I should probably say this. Every next NGS or genomic test or next generation sequencing or Foundation One or what's the others? Fulgent, etc. They test. They have different menus. They kind of have the same menu as they all test for TP53. They all test for PTEN, but there's some other tumor suppressors that aren't included in every one of them. So it can be hit or miss. Sometimes we get an NGS from this company and we have to get an NGS from another company because they don't reveal their exact testing protocol, which is annoying, but and especially if you have to get another biopsy, but that's the way it goes right now. Of course, we're working on making a conglomerate test too as well. Can cryotherapy be done on lymph nodes? Yes, cryotherapy can be done on anything. It can freeze any tissue in the body, normal, lymph node, organ, whatever. Whether you want to or not is a different question. But if you have a lymph node that has cancer in it, yes, I freeze those all the time. What are your next step in treating glioblastoma post-resection? It would largely be limited to gene therapy. Or there are some there's some viral therapies that I can infect the GBM, preferably over normal cells, and the immune system then attacks the GBM. Do I have good treatments with pancreatic cancer? I have better treatments with pancreatic cancer than traditional treatments, yes. Immunotherapy and gene therapy, and particularly cryoablation, depending on the anatomy. I've cured a number of pancreatic cancers, quote unquote, uncurable with these methods. It's a very difficult cancer to treat, but yes, it's possible. And yes, I have good results, considering what we're dealing with. Let's see. Do you treat T-cell lymphoma? It all depends on the details, the genomic analysis, which I'm happy to look at. All right. Any others? I'm down at the bottom, so whoever post. I did the cryo to two lymph nodes. Sadly, made them worse. Stable, yeah. So cryo alone. I mentioned earlier that if you cryo too much, you shut the immune system down, and so that would be one possible explanation. You can't treating cancer with one modality. If you just say I'm just going to cryo it, then that you can end up with situations like this. So a lot of it is experience on the clinician's part, how much cryo to use, whether or not to do it, when to do it, with what. But in general, if I can make a general statement, if you cryo too big of amount of tissue in a person's body, it will shut their immune system down and the cancer can proliferate. It's not the cryo causing it, it's the immune system reacting to the cryo, unfortunately. Okay. How about hurdle cell neoplasm? I'll have to ask me by email the thyroid. That's a specialty one. Stage 4 breast cancer of the spine. Clear tumor cell signa test, MRI of the spine. Now clear anything. So the CTC is clear. The MRI is clear. But you're saying this is Tanya, there is cancer in the spine. What I don't understand, if it's not on the MRI and there's no circulating tumor cells, by what method are they determining there's tumor in the spine? That's what I need to know. But if there is tumor in the spine, by any means, yes, it's treatable. Whether it's curable or not is a different story, but it's treatable.
We need a lot more details.
Yeah, yeah. All right, what else? I guess if I had to, here's the film bin ivermectin again. That was just asked.
Yeah.
Aaron, you want to talk about that again?
Yeah, so there's over about 380 drugs that help starve cancer. The ones that get the most notoriety are Fimbin and ivermectin. So we use those. There's other drugs, Celebrex, hydroxychloroquine, there's all kinds of medicines. So they are very efficacious. You got to know how to dose them and get the patients on the right dose. But again, it's not the end. It's not the only thing, So yes, we use them and they are effective.
Yeah.
Adjunct tool.
Yeah, there's I don't know, handful of medicines that have a minor anti-tumor effect depending on the dose, but the dosage is critical, and the timing and all, and the combination too.
Right.
So,
Right.
I mean, even Cialis has anti-tumor activity. The PDE5 inhibitors.
Right.
Yeah.
Right.
Okay. Any other
This
comments?
has been awesome. No, it's awesome. Just, things are changing all the time. We're always trying to educate and really inform people of updated medicine because it's changing. Even when you first started, things have changed.
Oh, dramatically, yeah.
So,
when I started, all they had was chemotherapy and radiation and surgery.
Right.
And that's why I went into what I did. I was an interventional, I was minimally invasive surgery, and I figured out I could cryo, I could stick a probe in and freeze the tumor and would kill it. And that was the beginning of all of it.
Yeah. And so, thank you guys for all your support, your questions, and exploring all these possibilities. So we appreciate your interest because that's how we're going to transform the future of health and humanity.
Exactly. Yep. Feel free to reach out. Need help with anything. Thank you.
Thank you.